Adrenal insufficiency arises when the adrenal gland is destroyed by disease or atrophies following pituitary failure or chronic corticosteroid use or abuse. In these situations, the amount of cortisol produced from the adrenal gland is insufficient to meet the body's needs during periods of physical and psychological stress or severe illness. The condition is associated with severe fluid and electrolyte imbalance and results in acute circulatory collapse. And the causes are sudden cessation of prolonged corticosteroid use or abuse, stress, for example, infection, in severe trauma, surgery, and dental procedures in a patient with undiagnosed adrenal insufficiency or patients on prolonged corticosteroid treatment, pituitary failure, autoimmune disease of the adrenal gland as Addison's disease, severe infections affecting the adrenal gland, for example, meningococcus, tuberculosis, HIV, and also congenital adrenal hyperplasia in children. And the symptoms are nausea, vomiting, weakness, collapse, abdominal pain, and diarrhea. And the signs that are usually elicited are dehydration, low or unrecordable blood pressure, darkening of oral mucosa, gums, skin, palms, and sores in some individuals. Evidence of corticosteroid abuse, for example, skin bleaching, Cushingoid appearance, and ambiguous genitalia, short stature, and failure to thrive in children, variable states of consciousness. Investigations are FBC, which may show anemia and eosinophilia, blood urea and electrolytes, which may show high potassium, blood glucose, which may be low, plasma cortisol, which may be low, blood film for malaria parasites if indicated, urine and blood cultures if indicated. And the main treatment objectives are to correct the fluid and electrolyte imbalance, to correct hypoglycemia, to replace corticosteroids, and to identify, cause, and treat any precipitating factor. Non-pharmacological treatment, there is none. So pharmacological treatment, acute treatment, first line treatment, we give intravenous fluid replacement in adults, 0.9% sodium chloride in 5% glucose, that's dextrose saline IV, 1 liter 4 to 6 hourly until condition is stable. In children, 0.45% sodium chloride in 5% glucose IV according to total fluid replacement. Fluid requirements rather, and also hydrocortisone IV in adults, 200 milligrams that's followed by 100 milligrams 6 hourly until condition is stable. And in children 6 to 12 years, we give 100 milligrams 6 hourly, 1 to 5 years 50 milligrams 6 hourly, and less than 1 year 25 milligrams 6 hourly. The IV hydrocortisone therapy may be required for several days. I do not rush to change to maintenance therapy. And when the patient's condition is stable, that is normal BP, cessation of vomiting, among others, you go on to maintenance therapy. So adjunct treatment in acute cases, so you treat infection, for example malaria, pneumonia, UTI, or stress-inducing condition if present or suspected, with appropriate medication. Maintenance for patients not previously on corticosteroids. The first line treatment, you give prednisolone oral, lifelong, in adults 5 milligrams morning and 2.5 milligrams evening each day, as in adults. In children, 70 micrograms per kilogram 12 hourly. Second line treatment, you give hydrocortisone oral lifelong, in adults 10 to 20 milligrams morning and 5 to 10 milligrams evening each day. In children, 280 micrograms per kilogram 12 hourly. Maintenance for patients on long-term corticosteroid therapy who go into adrenocortical crisis. for example, asthma, nephrotic syndrome. In adults and children, you restart the previous doses of oral corticosteroids given for the condition. Maintenance for patients who abuse corticosteroids. In adults, you restart oral corticosteroids or replace topical corticosteroids with oral corticosteroids. Prednisolone oral 20 to 40 milligrams daily. We gradually taper off the dose over several months, for example, reducing by 2.5 milligrams per month and eventually discontinue. Long-term corticosteroid therapy requires specialist supervision. Healthcare practitioners should inform patients of the following. The patients on corticosteroids should report to your hospital if they become ill. I should tell the doctor, dentist, nurse or pharmacist that they are on corticosteroids. The patients should not stop treatment if they become ill, have an infection, or undergoing a dental procedure. Rather, a doubling of the regular doses of corticosteroids is needed. We revert to hydrocortisone IV for even minor surgical procedures, including labor and delivery. A dose of corticosteroids must be reduced gradually if treatment has been for longer than 3 weeks and is to be stopped. Discourage the abuse of oral or topical corticosteroids. Referral criteria. So all patients suspected to have adrenal insufficiency should be referred after resuscitation to a regional teaching hospital for assessment and long-term management.